This week on the BackTable podcast.
I think it is powerful when other medical organizations make statements. I mean, OBGYNs are involved in advocacy until we're blue in the face. And, it does help to have other medical professionals who understand the medical system, understand what is evidence-based medicine, who can stand up and say, hey, this is important. This impacts people in other ways. We've had folks with the Cancer Center that have worked with us on op-eds. We've had folks from the law school, folks from across the medical center that have been involved in talking about these issues. And it's very powerful when medicine can be a united force to say, you know what, maybe we need to stand up for this. Maybe we need to speak out in a more vocal way. And also, our OBGYN colleagues, we're getting tired. We need some help.
Hello, everyone, and welcome back to the BackTable podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at BackTable.com. This is Aditya Bagrodia as your host this week, and I'm very excited to introduce our guest today, Chloe Peters from the University of Washington and Bev Gray from Duke University. How are y'all doing this morning?
Great. Thank you so much.
Yeah, thanks for having us.
So typically I'll do a little brief introduction of the guests, but I actually thought it might be nice to hear a little bit from your all's perspectives, a tidbit about yourself, how you became interested in women's health and women's advocacy issues. Chloe, would you like to start?
Sure. I'm currently a fourth-year resident at University of Washington. I'm on my research year right now, and it's great to get reconnected with you. I first met Aditya on my sub-I at UT Southwestern a long time ago, and was initially planning on doing some research in palliative care for my research year. And that was supposed to start July 1st. And on June 24th, the Dobbs decision happened. And it just felt like a really seismic moment that I wanted to look more into. And I've always been really passionate about women's health. And it felt like there were conversations that needed to be had, especially in the area of urology, around how this was going to impact our field, people in it, our patients, the workforce. And so I decided to change my research year topic. And I've spent the last year doing some work looking at how this ruling and abortion bans across the country might impact the urology workforce.
Great. Thanks for that, Chloe. Bev, would you mind introducing yourself to the listenership?
Yeah, so I'm Bev Gray. I'm an OBGYN at Duke University, and I've been working in OB for over a decade. And I was initially drawn to the field. I love surgery. I love the continuity of care of patients, and obstetrics is an exciting place to be. People probably have either some fond or terrifying memories of their OB rotation, but for me, it's one of my favorite places. And I was initially, when I started residency, I didn't have a path towards family planning, but eventually I came to that work partly because of an awesome mentor who really inspired me to do the work, and also just because of the gratitude that we felt from patients and how in a very short period of time you could care for someone and change the trajectory of their lives. And so that, for me, kind of kept me in the field. And when I was looking at residency programs, I, wanted to train at a place that offered abortion care as part of the training, but it was sort of a given. We were living in a time under Roe where people had access to care. And I was more concerned about geography, like being near my family, being in a place where my partner could have a successful job and career. And so those were the main things on my mind when I was picking a residency. But I feel like, so I'm the residency director as well, and I feel this last year in recruiting, there was definitely a shift in questions people were asking, where people were applying. And so there's so many ramifications from the Dobbs decision. It's where to begin.
Yeah, I'm sure kind of navigating these new issues as a trainee and as a trainer are getting increasingly complex. And as I was kind of thinking about structuring this, I thought it might be nice just to run through some basic facts. So from your perspective, I've kind of read some statistics out there about what proportion of women, families, couples actually seek abortion care services over the course of their life.
So it's incredibly common. And a lot of folks in this work will say, you probably know and love someone in your life who's had an abortion. So 1 in 4 women, by the time they reach menopause, will have needed abortion care. And so it's incredibly common. It cuts across socioeconomic status, race, religious affiliation. We're coming up on Mother's Day, and about 60% of patients seeking care are already mothers. And so people are making thoughtful decisions about their families, their futures, the families that they're caring for. And for me, in my life, my grandmother had an abortion when she was diagnosed with cervical cancer, and her abortion care saved her life. And this last 2 weeks in North Carolina has been very devastating because there's a new ban that's been passed in the House and Senate that will be vetoed by the governor, and there's a chance that there are votes to override this veto, which means that after July 1, it may be harder to care for people like my grandmother.
Yeah. Well, thanks for sharing that personal story. That's never easy. So maybe let's rewind to pre-June 24th of last year. If we could kind of get a landscape of what the U.S. was like in a pre-Dobbs era under Roe, as you'd mentioned, and then how things have shifted both once the Dobbs ruling came out and subsequently.
So even before Dobbs, access to care was variable, and there were disparities in access to care. So for a state like North Carolina, if you have Medicaid for insurance, which 50% of people do during pregnancy, it does not allow coverage for abortion care, unlike some other states like California, New York, Massachusetts. And that's because of the Hyde Amendment and being unable to use federal funds for abortion care. So states had to kind of pick up some of that cost, and some states chose to do that, many have not. So already you have many patients who were unable to access care previously because of cost. In the South, there were already inadequate numbers of providers in clinics providing care. So there's healthcare access, there's insurance coverage. For patients living in rural areas, they have to travel long distances to a clinic. And so this has just accelerated all of those difficulties and made the hurdles, made the hoops even higher to jump through. So, people were cut off from care before, but it's going to get worse.
Absolutely. The kind of practical components of obtaining an abortion, access to providers, the cost of it, the proximity to providers. But under Roe, maybe just to kind of make sure everybody's on the same wavelength here, you were allowed to and given the right to receive an abortion legally through federal protection.
Right, through viability, essentially. So that's what Roe offered protection for. So now all of the bans that are coming out pre-viability, in the past, you had protection from this precedent from Roe, and that sort of the rug was pulled out from underneath people. And so we no longer had that protection. So in North Carolina, we, for many years, had a 20-week ban on the books. And for a couple of years, that ban was enjoined. So I was part of a lawsuit that sued the state of North Carolina about the 20-week ban, and it was unconstitutional because of the protections from Roe. But as soon as the Dobbs decision came out, 2 months later, the 20-week ban went back into effect in North Carolina.
Viability is usually around 24 weeks.
Okay, yeah, I was just going to ask for just a couple of terminology. So viability, 24 weeks. Enjoined, that's a foreign term to me.
Yeah. Well, if you're in this field, you have to have like a mini law degree to be able to do your work on a day-to-day basis. So spend a lot of time with lawyers, a lot of times, talking and reading through like briefs and legislation and things that you're not trained for in medical school. So enjoined just means that that law was not in effect for a period of time.
Okay, and Chloe, Dobbs came out June of last year, and maybe just describe in lay people's term what exactly that was and why that fueled your interest in this area.
So the Dobbs ruling essentially said that there is no constitutional right to abortion. So it overturned Roe and Casey versus Planned Parenthood, which were the two Supreme Court rulings that had provided protection for abortion care. And so it basically allows states to regulate any aspect of abortion care that's not covered by federal law. And I think it's really important to just define abortion, which is just the removal of the products of pregnancy from the uterus. And it has nothing to do with the setting. It has nothing to do with why that's happening. It's just a medical term. And it's used in miscarriage care. I think that the term abortion has become so politicized that people have forgotten that this is a medical term and a medical procedure that doesn't have anything to do with the reasons why somebody is going in for one. And so I have known people who've had abortions. I just really strongly believe that it is an essential aspect of being able to live a healthy life, and that choosing if and when to become a parent is fundamental to your ability to be equal as a human in this society and to control what happens in your own body. And so it's something I felt passionately about. I realized when this ruling happened, and there were very quickly a number of states that passed complete abortion bans. And so this is changing all the time. And I think as of right now, there are 15 states that have near or total abortion bans. So those are states where abortion is completely illegal. Some have exceptions for rape or incest, some do not. Some of those require a police report, some don't. Some have exceptions for fetal anomalies, and some don't. I believe every state now has an exception for life of the mother. Until a few weeks ago, that was not true in Tennessee. And then there are a couple states that have 6-week abortion bans, which are essentially basically near total abortion bans. And I realized that if this ruling had happened when I was applying to residency, my list would have looked really different. And 2 of the top 3 programs on my list would have not been there. And I realized that if state abortion laws impact where people choose to live and work, then there are really significant implications for our workforce that we need to talk about. And people are having a lot of conversations, obviously, around the personal implications of abortion bans and of Dobbs and how that's going to affect people who can get pregnant and patients, providers. But talking about how that's going to impact the urology workforce, I think this has been a much bigger conversation in OBGYN because it more directly, obviously, impacts that field. But we are not immune to it. And I wanted to show that.
Yeah, absolutely. I mean, as I kind of prepared for this podcast, I'm certainly not an expert in abortion and policy, but it's incredibly complex. As you've mentioned, you read about the complete abortion bans, the near total, the 6 weeks, and I think most people would agree that by the time somebody's noticed that their menstruation is a little bit late, lo and behold, you go finally make an appointment with the doctor, that ship has sailed. But one of the terminologies that I came across fairly consistently was the idea of restrictive versus non-restrictive states. Could you maybe just comment a bit on that?
Yeah, there is no, formalized definition. A lot of what we took our data from was the Guttmacher Institute, and restrictive states include all of the states that have complete abortion bans or bans that have something like a 6-week gestational limit, which in practicality is almost a total abortion ban. So I think that's kind of the most restrictive category. There are other states that have laws that require things like a 72-hour waiting period, which also imposes a lot of difficulties and hurdles to women actually obtaining an abortion, not covering abortion with federal or Medicare funding. Other restrictions in the laws, requiring people to look at an ultrasound and receive factually incorrect scientific information, things that hinder the ability to obtain an abortion, but still legally will allow a woman to get one if she is able, or a person who can get pregnant, to leap those hurdles. Those kind of are maybe more in a restrictive category. And then there are protective states where in the state laws, people have the right to an abortion and that's legally protected.
Okay, super helpful. So we obviously have a urologist and an OB-GYN on the show today. It seems like, without being myopic, that would be kind of epicenter type subspecialties that would be affected. But in your perspective, why is this beyond OB, or beyond urology? Can you maybe just talk a little bit about how a person, a male, a female, a seasoned attending private practitioner, a fellow, a resident, a student, why does this matter?
It matters in so many ways. So I'll talk a little bit about one of the first studies that we did, because I think that answers that question, which was a survey of members of the Society of Women in Urology. And this is a subset of the urology population, but an important one, and the group probably most directly impacted by these laws. We did a survey of SWU members, and we found that 60% of them said that when they're looking for their next job, there are states that they will avoid specifically because of the Dobbs ruling. And 41% of practicing urologists said that if this ruling had happened when looking for their current job, they would have picked a different position. 42% of residents and fellows said that if this had happened when they were applying, it would have changed their rank list. And those are huge numbers. And so just looking at that, if we think about the fact that urologists don't provide abortions, but there are urologists who may need abortions. We take care of patients who may need abortions. We take care of the sequelae of pregnancy with prolapse, incontinence for many patients. And a third of our trainees are women right now. And if for no other reason, if more than half of them avoid living in states with abortion bans, then we're going to face really serious workforce shortages in those areas. And we've done some other work looking at the distribution of urologists across the country, and we know that the states that have the most restrictive abortion laws also have the lowest densities of urologists. So they have the fewest urologists per person. They already have workforce shortages. And if people are deciding where to live with their family, and you think about somebody who's coming out of training, maybe they're in their early 30s, maybe they want to get pregnant, and you look at a state where if you had a miscarriage, you would not be certain that you could get appropriate medical care. That's really scary. And we had so many comments from people who said that they don't feel safe living in those states, which I understand. And so whether or not you can get pregnant, there are people who have partners or other people they love. There are older urologists who made comments in our survey that they have adult daughters and they were looking to move because they want their daughters to feel comfortable visiting them if they were pregnant. So I think these just have really wide-ranging implications. And if we just look at the numbers and look at the data, we need to be concerned, because if we ignore this, then 10 years down the line, we're going to find ourselves with no urologists in certain areas of the country. And if that happens, then who's going to treat your septic stone at 2 a.m., or who's going to do your prostate biopsy? That impacts all other areas of urologic care. And we know that having less access to urologists leads to worse urologic outcomes. And these laws are going to impact where urologists go.
Yeah, I think it's one of those things. It seems more actionable as somebody who's still in the decision-making phase of their life. And, by all means, I don't think this is just the medical professional part of one's life, but I would imagine that women seeking out colleges and universities or their first jobs, this is all playing in, and you're going to start seeing, a change in the absolute number of people and maybe perhaps the type of people that are pursuing living in a certain geography. And if you're applying to college or medical school or residency or fellowship, the ball's in your court to some extent, I would say. And it's a little bit easier to shift. But I mean, Bev, maybe your perspective, I think you mentioned that you've been there for about 10 years, either you decide, am I gonna fight the good fight, or am I getting out of here because this place is not consistent with, how I see things?
Yeah, I mean, I'm a native North Carolinian. My family still lives here. My husband has a great job here. I think, our kids are established here. I'm committed to the people of North Carolina. So I sort of fall into that category. But I totally understand that this has created such challenges for people doing this work. There's this idea of moral injury where you're in your job, you are hamstrung by the laws that are in place in your state, and you're unable to provide care when it's medically necessary, sometimes without involving a lawyer, sometimes not caring for people until they're at the brink of death. And it is impossible to ask people to do that forever and not feel the strain of that on their life. And so I've talked to people who are very committed to this work, but these restrictions are tiring. I know people that have left states to move to other less restrictive states. I took a few notes of just while you were talking, Chloe, because there are so many other things that can come up. I mean, so most residents are of reproductive age. And luckily, we're in a time where, we're making it possible for residents to start families during residency and making huge progress with not making residents defer their family planning choices until later. And so let's say you move to a restrictive state. What if in that state there are restrictions around what insurance can cover? So your insurance may not cover abortion care, even though you're able to travel to another state to get care if you need it. if your insurance doesn't cover it, not only are you paying out of pocket to travel, but you're paying for that care. People make decisions based on their partner's needs as well. And so, even if it's a male resident, they have a female partner, they may not want to go to a state that's restrictive for that reason. I think the downstream effects are that, people often stay in the state where they train. You make connections when you're a resident. You learn about the jobs there. You sort of envision yourself working in a job that you see or you're around. And so there are those downstream effects. So if people make decisions about not training in a certain area, you're losing out on that talent and those amazing people who could have come to that area and stayed there and made a life there. In a lot of the states that have strict bans, there are also states that have not expanded Medicaid. And so that impacts how patients engage in care and have access to care. And I think it's harder work to live in a state that doesn't have expanded Medicaid because you're caring for more patients who have many more struggles to engage in the medical system. And so it's harder work. It's important work, don't get me wrong. And I think, we're attracting a lot of residents who are really motivated to advocate for patients and provide this care. But it's hard work, and it's almost a different job in and of itself. There are so many days that I just want to come to work. I just want to do my job. I don't want to have to talk to a reporter. I don't want to have to talk to a lawyer. I just want to take care of people. And unfortunately, that has not been what my life has been like this last year. And it gets really tiring. I think one other point to make is that in states with very strict bans, I think a lot of people are really concerned about operating on patients who are pregnant. What if I have this patient with an emergent urologic need and she's in the first trimester? What if she miscarries from this surgery? Are they going to accuse me of causing an abortion? Am I going to be under a microscope? And I've heard people express that. In my mind, I don't think that should happen at all. But, in some of these restrictive states, I think people feel very much like they're under a microscope.
Well, when the risk of being accused of that is a potential felony charge, getting your license revoked, having $10,000 fines or things like that, that's a really big risk to weigh.
Yeah, I think it's worth mentioning that Bev and I don't know each other. I have a dear friend that outside of work, I really respect and admire what they've been able to do in terms of increasing awareness around worsening periterm morbidity for mothers. And I reached out to him and I said, hey, do you think we could have a chat about workforce issues as a result of Dobbs? And suffice it to say that he said, I would love to do that. Shared exactly what you're kind of describing, Bev, just the beatdown of taking care of people and all the paperwork and the scrutiny and the politicizing that takes place. But the bottom line is he ultimately said, I cannot do this because I am at a state institution in a extremely restrictive state, and you better believe I'm going to get a call to the ivory tower if I go and express my opinions, to the point where they've written papers, editorial comments, etc., and other people have to kind of share that work. So I can empathize from conversation with my friend about a lot of what you're saying. So Chloe, you talked a little bit about the survey work, particularly among trainees and so forth. Are we actually starting to see this? I don't know if this data exists or not. Are the number of applicants to restrictive states, highly restrictive states, changing urology OB across specialties? Is this a theoretical thing or is this a real thing?
There was a recent study that was just published actually looking at all of the NRMP matches, so that actually doesn't include urology. And they saw that there was a greater decrease in applications across all specialties to residency programs in states with restrictive abortion laws compared to states with protective laws. And in OB, that was pretty significant. I think it was about a 10% decrease in applications to those programs. In urology, so we did another survey. We surveyed all of the urology applicants to the match for this cycle. And we had 42% response rate, which is really great. And 1 out of 5 took programs off their list specifically because they're located in states where abortion is illegal. And that's a really big number. Our match rate as a specialty the year before was 66%. So this was a group that came into this match knowing that 1 out of 3 people didn't match last year and that they're going into a very competitive specialty. And even knowing that 20% of them took programs off their list. And almost 60% said that if they match in a state with restrictive laws, they would worry about their health and safety or their partner's health and safety. So people have in the last year made decisions about where they want to train based on these laws. We don't have data looking at where people are taking jobs yet, but that's something that we want to look at. But we know, like Bev said, more than half of trainees end up staying in the place where they trained in that area. And so if people are choosing to avoid certain states because just to even apply or put on their rank list for residency, that's going to change the demographics of the trainees in those areas. And that's going to have repercussions down the road for the people who are practicing medicine there in all specialties. And we, anecdotally, we had people just write comments that they changed their fellowship match list after the ruling happened, or people who were going to take a job and they turned it down.
Bev, are you seeing this in your most recent interview cycle? Is this something that's coming up from potential match candidates?
So Duke is a top 10 residency program and has been for decades. And I think we had roughly the same number of applications. The AAMC data did show that in restrictive states for U.S. seniors, there was a 10% decrease in applications. So like Chloe mentioned. And then with some sort of ban in place, it was probably a 6% decrease. And then there was like a 2% decrease overall, I believe. So it didn't feel quite the same. This year, we also had some changes in our application cycle. We have signaling now. So like that was a little bit different. And so it's hard. It's kind of comparing two different processes. I mean, we still had outstanding applicants to our program. It's hard to know. I mean, it's just, it will take a few years to see what's happening. Our residents often, about half of them subspecialize and half go into either academic or private practice once they graduate. This year we had almost all of our residents go into fellowship. So it's a little bit of a different year. And we occasionally have folks that pursue complex family planning for fellowship. I would say that's probably a little bit more over these last few years, but some of that's probably dependent upon faculty mentorship and other things that we've been supporting here. I do think more people are asking questions about it, though. Like, what is like the legislative climate in your state? So the point of interviews, we still had access through 20 weeks. And so we're kind of a purple state, a lot of advocacy opportunities, but having rights chipped away over time. And especially with this new ban that was passed by the legislature last week, I think it's going to have a real impact. And we will have to change, how we get opportunities for residents. So we're looking at other external rotations, other ways that residents can get training. Ideally, they would get that training kind of continuously through their residency program, not just a month here or a month there. I think it's better to get that consistently.
Yeah, as I was kind of reading some of what's out there, it does seem that there's been programs that are welcoming to other trainees to come and observe and learn, and in person or virtually. But clearly that's also not totally non-disruptive. I mean, if you have other stuff going on, a family, et cetera, just to pop over to a state that's non-restrictive is not trivial.
Yeah, no, you have to get a medical license in that state. There are, training agreements. It's, it's not just like, okay, well, you'll go to this clinic this month. There's a lot of preparation and a lot that goes on behind the scenes to make that happen.
We've gone from abortion being a federally protected right, essentially, prior to viability, with some varying levels of restrictiveness built in through the actual practical implementation of abortion. That was Roe. Now we have Dobbs, where essentially the decision-making is in the hands of the states, and we've seen one polar extreme where it's a total ban, and then a lot of in-between amongst restrictive states that, again, make it significantly challenging. And, here we are today assessing the impact on the workforce in medicine and a little bit more in depth on urology and OB. What's the kind of transparency obligation for any program as it pertains to this? I mean, I'm guessing most people are not oblivious to what the policies are, but is this something that should be brought up during medical school, residency, fellowship, job recruitment?
So we've been doing interviews with urology applicants to talk to them a little bit more about that. And a lot have said that they would have really appreciated hearing about this because it's really scary to ask. You're in a vulnerable position when you're applying as a trainee, and it's a hot topic. People have really strong feelings in a lot of different ways about it. So a lot of people don't feel like they can ask, but it is going to significantly impact their life. And I think it's really important for both training programs and employers to recognize that however you feel about abortion personally, you may have employees or trainees who need abortion care for whatever reason. And you just have to understand that might be a part of their life and that they may need help, whether that is help with logistics, taking time off to go out of state to travel to get something if they or their partner needs an abortion, financial help just rearranging a schedule, just like they would if they were pregnant or having a baby. These are medical needs, and you don't have to personally agree with it, but you have to recognize that people who are working for you may need it. And also, if you are trying to recruit a talented workforce and you're trying to recruit a diverse workforce, especially if you live in a state with restrictive laws, you have to consider that. And whether you want to make policies that specifically address it is, up to each individual group, but you might have a hard time recruiting certain people if you live in a state with really restrictive policies. And so having some kind of signal to people that you would help them or support them in that situation would be helpful. So, especially if in places, urologists, there are clinical implications too. We don't provide abortion care, but we do prenatal counseling for GU abnormalities. We do vasectomies, we do infertility care. All of those things do have really direct impacts from the Dobbs ruling. And we're already seeing impacts with rising vasectomy rates and things like that. So people are paying attention to it. And it's a little bit naive to think that you can just turn a blind eye to this entire topic if you live in a restrictive state and think it won't impact you at all.
The Ryan Residency Program, which is out of UCSF, created a guide for at least OBGYN residents in thinking about applying to kind of restrictive or purple states and how to ask those questions delicately, how to get the information. And it was meant to be like a resource guide for OB residents. And I think it probably would be useful for other residents kind of making those decisions. One of the best resources for understanding what's going on in individual states is the Guttmacher Institute has up-to-date data about access and laws, and you can get like a fact sheet for each state. And so that can be helpful. But I do think the culture of a program impacts your life as a resident in so many ways. Like, will your residency program be supportive of you with whatever health challenge you encounter as a resident or whatever need you might have that is unanticipated? And so I think there are ways to ask those questions as well and still get the information that you need.
Yeah, I think, for urology, it's been really interesting, even over the course of my involvement in urology, to see the increased diversity within urology, increased representation. Certainly, I think when I was considering it as a field, it was still a predominantly male-dominant, white male-dominant field. And, the energy, the emphasis on things that are pertinent and relevant in the 21st century is really wonderful to see. And I get the sense that it doesn't really kind of matter where you are for a urology residency. It's typically a forward-thinking, progressive group of people. And I say all this because I think one of the things that got a lot of press in our world was the statement that the American Urology Association put out on behalf of its membership, and then a bit about the backlash. Chloe, are you familiar with that whole kind of process?
Yeah. The AUE essentially put out a statement. I don't have the text in front of me, but that basically said that they defer to their colleagues in the House of Medicine on the abortion issue, and that they don't condone any ruling that might interfere with the provider-patient relationship. And there were some very strong reactions, and I know that a lot of people wrote to the board, and we heard from some of the board members at the AUA meeting actually about the response. There were a lot of people in our survey who felt really unsupported, felt that the statement from a professional medical organization just made them feel like they don't have a place in this specialty. And there were a lot of comments that abortion is evidence-based medicine, and it's our job, and it's the job of professional medical societies to support evidence-based medicine, and that includes abortion care. And, again, I really recognize that this is a complex topic and that people have some really, really strong feelings about this. And I think that there is a general sense that a society needs to recognize the needs of its members and its patients and follow medical guidelines. And there is a lot of disappointment that there wasn't a stronger statement just that abortion is healthcare and that needs to be something that's protected.
Yeah, and I mean, I was also one of those people that was just like, that seems a little, I think lukewarm is a pretty good term for it. And then they, to their credit, in my opinion, they followed up with try to dig in a little bit deeper on who's the demographic that feels this is relevant to our field, and to maybe paraphrase, suffice to say that younger people and women felt that this is a priority, whereas more senior people that have been in practice for a long time, predominantly white male, felt like things were adequate with the statement. Is that roughly fair?
Yeah, it's a great example of the need to look closely at data. Because their overall statement was that I think 57% or over half of respondents, the AUM members, said no to the question, should we spend time and resources on advocacy related to some of these issues like abortion care? But then when you actually break it down by age, there's a huge, very stark difference between generations, and 2/3 of trainees said yes, compared to 80-something% of retired urologists who said no. And so when you actually look at the data, younger urologists and people who are coming into this field really clearly want advocacy on abortion, and the vast majority of those, over 90%, want the AUA to oppose any policies that restrict access to abortion care. This newer generation is a group that really cares about this topic. They want advocacy. We already can see that it is impacting where they're choosing to live and work. And 30% of urologists are 65 or older. And so we have a lot of people retiring soon. We have a big workforce shortage that's already happening and just going to get worse. And younger urologists are going to move up and kind of replace some of these people who are growing older. So I think that the attitudes of the field are shifting, and it's important. I know that the AUA has been trying to sort of please all of its members and then therefore not really pleased anybody. And it's a tough spot to be in. But I think they should also recognize where the field is going and what things are going to look like in 5 years, because I think it's different.
I think it is powerful when other medical organizations make statements. I mean, OBGYNs are involved in advocacy until we're blue in the face. And, it does help to have other medical professionals who understand the medical system, understand what is evidence-based medicine, who can stand up and say, hey, this is important. This impacts people in other ways. We've had folks with the Cancer Center that have worked with us on op-eds. We've had folks from the law school, folks from across the medical center that have been involved in talking about these issues. And it's very powerful when medicine can be a united force to say, you know what, maybe we need to stand up for this. Maybe we need to speak out in a more vocal way. And also, our OBGYN colleagues, we're getting tired. We need some help. So for all the urologists that are listening, that are thinking about getting involved in advocacy, this is an important issue. And so reach out, find ways you can support your colleagues at your institutions.
You mentioned something earlier, Bev, that certainly struck a chord with me, especially with Mother's Day, in 2 days. I'll share a little bit of a personal story. So we have 2 boys. And about 5 years ago, roughly around this time, we were pregnant. My wife was pregnant, and we were living in Texas, and, things were kind of cruise control, supposed to have a little baby girl. And, we go to the OB, and it became very obvious that things were not going well. Fortunately, being in the medical field, we were able to get a lot of information quick. We got a fetal MRI and met with the pediatrics team, the OB team, and suffice to say that, things were not going to be sustainable. So we, I called my chairman, his amazing person. I was like, hey, we've got to split. And at that time, we're into about 30 weeks. So there were very limited options. And that was, I think, that post viability is clearly a super duper hot button area. But at that time, we're kind of freaking out, doing research. And one of the important things and amazing things was that, there's a whole team of OBs. It was intense for everybody involved. They were like, this is not going to end well. Here's some resources in Colorado and Santa Fe and California. And we made the extremely difficult decision to fly to California and get an abortion. And the whole thing was it was brutal. It was just intense. And despite the fact that we knew that this baby was not going to survive, despite all that, it was crazy. And fortunately, we had the means to do that. It was crazy expensive. Nothing was covered. Flying to some random spot and putting yourself up and thankfully my sister's in LA, but despite that, it was awful. You want to, especially in the context of something terrible like that, you want to be kind of in a familiar setting. And I guess it just takes a lot of this hypothetical stuff. And that was, one end of the spectrum. I kind of acknowledge that, but this might be the day-to-day, that, whether it's medical or, there's maternal health, there's all the super unpleasant things, rape and incest. But, for people to just have to drop their life and head out elsewhere it's crazy. And, we went to a support group after about 18 months. It was called Ending Unwanted Pregnancy. And that was also just a totally mind-blowing experience to sit around with people that have gone through something that you really can't appreciate until you've done it. And I'll never forget, there was somebody there that shared her story and was telling about her very conservative family and how her grandmother was like, well, it's okay that you did it because you had to. And the person in the group was like, you can't take that stand, It's either you're okay with it or you're not, but it can't be an exception for me. And, hats off to my wife. She's been super proactive in terms of advocacy and sharing her story with the Texas legislature while we were there. It took a while, we weren't kind of ready for this a week afterwards, but sometimes I think it's easy enough to be this is something abstract and people don't go through it, or people like me don't go through it. But it's not, is kind of my thing. And I remember, flying out there, it was Mother's Day and she looked pretty pregnant and it was just kind of a wild thing that takes this and has it hit very close to home.
Well, thank you for sharing that story. I mean, it's a very powerful story. It's a heartbreaking story. And I think it highlights that people make thoughtful decisions about their life, and parents do not want their children to suffer. And that is an act of motherhood right there, not wanting your child to suffer. And I think people forget that. They get caught up in the ideology and the politics of this, but they're real people living real lives where things happen that we can't anticipate. And you can't create a list of exceptions, because there's always an exception to the rule or an exception to the exception. And I feel for you and your family having to go through that. That's something that you'll probably carry around with you forever.
Well, it certainly inspired us and our family to do what we can, with advocacy. And, maybe as we conclude here, some parting thoughts and kind of where we are. And maybe importantly, what can we do? Sometimes I think these large political scale things they're a little overwhelming, but what can we do, as a person, as a field, to help get back what I would consider fundamental healthcare?
I mean, I think getting involved with your local medical societies, because they do often make statements. And I think as more progressive physicians are in a part of the field, like Chloe was mentioning, things will change. I mean, this younger generation is more progressive than ever. That gives me hope. And I think Chloe's generation, y'all are going to make some important things happen. I feel really bad that there's so much put on your generation that we've got to work on, but y'all are already doing amazing things. So, getting involved with these organizations that have typically not been very diverse, that have been more senior folks in the field, injecting that change into your local medical society is important. Voting, understanding who your legislators are. Reach out to your legislators, to your institution, and start having conversations with them, because there are so many things in medicine that we can advocate for, whether it's Medicaid expansion or other issues that you see on a daily basis that are impacting your patients. And then when an issue like access to abortion comes up, you have those relationships and contacts, and you can keep those lines of communication open. op-eds, letters to the editor, those are really helpful about issues around abortion, especially when it's coming from people who are not OBGYNs who see the impacts in their own field.
Yeah, I think there are a lot of different ways to get involved, and people often underestimate the power of local involvement, whether that's with your city council, state representatives. They're often a lot more accessible than national level politics. And really just talking about it, I think so much of this, when people have really strong opinions about abortion, and then they hear a story like yours, Aditya, which is so powerful and so difficult, it opens people's minds, I think, a little bit more when you start, every time you realize more and more of the nuance that goes into it, when you realize that there are people who are having an active miscarriage and can't fly out of state to get an abortion just medically. I think we need to talk about that. It's still something that is surrounded with a lot of stigma and a lot of shame. And when 1 out of 4 women have had an abortion at some point in their life, we're surrounded by people who have gone through this. And every single one of those stories is unique and complex. And understanding what goes into that, and understanding that these are just decisions that have to be made by the person and their doctor, I think really that understanding only happens when you talk about it more. And then we talked about things like policies to help trainees or employees feel protected if they need to travel out of state. Being open about the support that people would have, I think is really key.
Well, I certainly appreciate that. And, thanks for sharing your expertise, helping to raise awareness on how this impacts all of us, is the way I kind of see it. And just like most things in life, everything's fine until it's not fine, or whether that's for you or a loved one or a colleague, statistically, there was somebody that you know and love that it was not fine for, or it may not be fine for in the future. And we've got to raise awareness, and I remain optimistic, and, with the energy of the upcoming generation, with our progressive past in this field, that we can kind of get back to something that's safe and acceptable. Well, thanks, Chloe. Thanks, Bev, so much for your time. And, I learned a tremendous amount today. Thank you.
Thank you so much, Aditya.
Yeah, thanks for having us.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz, with support from
Devante Delbrun.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.